Thank you very much. So PCR, when it has occurred, the best thing to do or the most important thing to do is a PCC. And if a PCC is achieved, then the intraocular lens implantation can be very, very smooth. However, if in a case where a PCC is just about impossible, when it is impossible, then how do you do? So let's look through this video. And this is a big nucleus that is there. And you can see that if I have to remove this nucleus, there's a lot of maneuver that is to be done. So I put in the viscoelastic, high molecular weight viscoelastic in the bag. And then that separates out. And at least if I'm trying to do phacoemulsification, and this is phacoemulsification under as low parameters as possible, trying to take it up. And I'm constantly looking at one particular tissue. And that particular tissue, I'll just pause in between, that particular tissue is the iris. The moment you're looking at the iris, you will notice that if the iris tremulousness is too much, that means the viscoelastic has leaked out. So you need to fill in viscoelastic at that point of time and then go ahead with the phacoemulsification. So that's a very small but a very important trick. The next thing is, if you have been able to compartmentalize the different tissue at the different levels, then this dry aspiration or with the fluid aspiration of the remaining cortical matter can be done. But remember the fact that if it has to be done, it must be done gently. And the moment you feel that you have actually disturbed the vitreous or the vitreous has come in, then what you need to do is to do a vitrectomy before you go on to any amount of aspiration. Because what one is not supposed to do is aspiration of the vitreous. If you aspire the vitreous, and look in this case, the vitreous has come and you can see the ovalization, I'll definitely have to do a vitrectomy for this. And triamcinolone assisted vitrectomy is what every one of us should do for two reasons. One is that you do understand that the whole amount of vitreous has been taken off by the vitrector. Next thing is, it actually improves the tissue healing, and the cornea the next day is in a much better scenario than you would have without the use of triamcinolone. That amount of triamcinolone for just about a minute or a half a minute works wonders for the corneal endothelium. So let's keep this in mind as well. When PCC is possible, what is that situation? Now here we have a central rupture. We have a central rupture, and this occurred when we were going ahead with it. And as we go ahead with it, this rupture that we have to do is, now if it is a small central rupture, then you really can do a very good PCC, and you don't need to be worried about the integrity. PCC is not difficult. Therefore, if you have detected that is a small rupture, best is to take time off. It may take you 2 minutes to 5 minutes, but get a PCC done. And you can see that this PCC was done well. And now any amount of manipulation in the bag is possible. And you can go ahead and place not only a single piece lens, but also a multi-piece lens inside the bag. So once the multi-piece lens is placed inside the bag, again, you need to take out all the elements of the viscoelastic, and of course, watch for any amount of vitreous in the anterior chamber. Here, of course, in this case, vitreous would not possibly arise into the anterior chamber, but one needs to be sure again. So let's look into this situation where you can see that it has been a difficult situation, and I've had difficulty in doing this surgery. We have these 5 hooks already, and we have what you can see, it is the rhexis is a small one, and the rhexis has been done. Therefore, you understand that it was a small pupil. I did a small rhexis. I had trouble taking out the nucleus, and then thereby we have this situation. So, but even in this situation with this small rhexis, anterior rhexis, you can still do off a posterior capsular rhexis, and once that is done, you have a better stable bag. Now here I'd like to just tell you that the vitrectomy that can be done has to be very, very particular, and you need to take up the vitreous. Here, of course, if you are doing anterior vitrectomy, you should have a good amount of infusion that is coming in, and the vitrector should be actually cutting the vitreous, and do not put too much of methyl cellulose or viscoelastic, because the wastage of the cutter cutting the methyl cellulose itself is not desirable. What you need to cut is the vitreous. And here, of course, you can go in from the pars plana and do a pars plana vitrectomy. That is also desirable. So here we have completed it. We put in the 3-piece lens in the bag, in the sulcus, sorry, and we capture it. Let us go to the next situation. And in this situation, it is a PCR with nucleus and with the cortex there. So this is a PPC, a classical PPC that we have. And here we have the nuclear fragment is also there. So I'm scared if I do any more manipulation, we will lose the Rex's possibility of a PCC. So I go ahead and first do of the PCC. So the importance here shown by this video is do of the PCC first if it is possible. If it is not possible, you can go ahead for the manipulation and the removal of the next part of the cortex and the nuclear matter. So here the important take home is, if it is a small rupture, put in viscoelastic, have the layers of the viscoelastic nicely there, and then take off the rest of the remaining parts of cortex and nucleus. Here, as you see, the nucleus is still there, and I'm putting in the lens because I do not want to disturb the vitreous as much as possible, and thereby I know that I can definitely remove this amount of nucleus that is remaining, and that's not a priority as of now. Priority is getting the IOL in place. In the bag here we have placed it, and getting the nucleus out after that. And of course, if there's any amount of vitrectomy to be done, that needs to be done. So let us not think of which one to come first. The priority is always, if it is possible, the PCC must be done. And let me again assure you, the PCC is not a difficult procedure. It can be done quite well. So here we are, and Ajay has already alluded to in his previous presentation, PCC is impossible, and this is a case of a posterior capsular rupture where the PCC is not possible at all. And you can see the horizontal the rupture that has already occurred. And here in this rupture, Ajay told very, very important things. See, after seeing this video, one must realize that it is not to be done for every situation. It is not. So in this situation, again, I'll repeat what Ajay said. Posterior capsule which has ruptured is curling up, which means that there is a vitreous upthrust. Then you have to be very careful because that bag has not opened. The anterior capsular rhexis and the portion between the tone posterior rhexis is not open. So the posterior capsule and the anterior capsule should be in different planes for your in the bag implantation of the intraocular lens. So this is a very important thing. And here we could see the space, and you have to visualize that the space is there. And the next technique is you have to implant the lens not directly into the bag because you might harm the vitreous, but it has to be on the plane of the iris. So that's trick number 2. So if you have implanted on the iris, the next procedure is making a knuckle of this haptic optic. So we made a knuckle, and under direct visualization, we placed it inside the portion of the bag, anterior capsule, and the tone posterior capsule. Similarly, again, I'm going to stop and show that this is the way, this is the technique that you have to do. That knuckling effect has to be there. Here, I must again warn you, if you are not at times, because the pupil is coming down and you're not able to visualize the tone parts and the anterior capsule, then these are difficult situations. You might don't be groping in the dark at all, because no more harm than good can be done at the end. So here again, we are able to visualize. So we place it with that knuckle. The knuckle first should go in. If the knuckle has gone in, the haptic will follow. So these are small important things. But of course, you have to have your savior, and the savior is the three-piece intraocular lens, which again can be placed. If you're not able to do the right procedure and place it in the right plane, just take it out. It has to be taken out, and there would be handling of the vitreous and all that. Those things I understand, but don't leave anything to chance in these cases, because if you have not been able to put the leading haptic in the bag, it might actually dangle down, and you might have a more problematic situation than what you encountered. So last video that I would share with you is, this was a little more a difficult situation, because the same situation again, a PTC which go from end to end, and but still can we place it in the bag. So here we tried to place it in the bag, and here the situation was that the amount of cortex that there was much more than in the previous situation. But all the time, as you can see, I'm doing a dry aspiration on all the time. Now, what is the deviation from the previous video? The previous video had the transverse type of tear. In this video, it is a longitudinal tear. Can you see that? It's a longitudinal tear. So, and one part of the tear is eccentric. So we have a smaller capsular bag in one place, a larger one in the other place, and it is longitudinal. So let's see how we can go ahead. So we put a blob of high molecular weight viscoelastic in between, just to have it safe and sound. And then we place, as we said, the leading haptic onto the iris, and then turn it around. And here, that knuckling effect is very difficult, and I'm trying to place it in the bag, and it has to be under, as I said, very good visualization, because if this is not, then we might lose the bag. So I could visualize that it has gone in the bag, and you can see that the anterior capsular axis is up there. And now I can do this knuckling on this side, which is simpler definitely. But again, let's have a very nice and widely dilated pupil for all these little tricks that we need to do. Any case, I would always tell, let us be as safe as possible. If you think you're not confident to do a procedure like this, please do not required to attempt it. You will achieve as good from any other procedure, or placing the three-piece intraocular lens on the sulcus and capturing it. Thank you very much for your patient hearing.